Stroke, or cerebral infarction, is an acute focal neurologic deficit caused by disruption of blood supply to an area of the brain and is a major cause of mortality and disability worldwide. Stroke can either be ischemic or hemorrhagic in etiology. About 85% of strokes in the U.S. are ischemic, with emboli from cerebrovascular disease making up a significant portion. Risk factors for ischemic stroke include many of the risk factors for atherosclerosis, such as hypertension, smoking, and diabetes. Symptoms may be self-resolving, such as with a TIA, or permanent, as in a stroke. It's important to remember the laterality of the symptoms in relation to the suspected carotid disease to ensure that the cause is not due to a different etiology. Symptoms are often in an MCA distribution and can include the following: aphasias or word-finding difficulties, dysarthria or difficulty speaking because of facial muscle impairment, contralateral motor or sensory loss, and amaurosis fugax, or transient unilateral vision loss on the side of the pathology due to occlusion of the ophthalmic or central retinal artery from emboli. This is seen on fundoscopic exam as a Hollenhorst plaque. Duplex ultrasound is the gold standard of imaging and evaluates both anatomy and flow velocity patterns to determine the degree of stenosis. Stenosis less than 50% has a corresponding peak systolic velocity less than 125 centimeters per second. Remember, the internal carotid supplies the low-resistance vascular bed of the brain and has continuous forward flow throughout diastole. Stenosis greater than 70% corresponds to a peak systolic velocity greater than 230 centimeters per second. As a general rule of thumb, doubling the percentage of stenosis will double the velocity. A few landmark studies are critical to know. First, the NACID study demonstrated a benefit of carotid endarterectomy over medical management in symptomatic patients with stenosis greater than 50%. The ACAS and ACST studies demonstrated a benefit to patients with asymptomatic disease and greater than 60% stenosis. Finally, the CREST trial showed no significant difference between endarterectomy and stenting with a composite endpoint of stroke, MI, or death. However, more strokes were seen with stenting and more MIs with endarterectomy.